Hello, my friends. A few days back, when I was putting up the promo of this lecture, I talked that all of the types of shocks that we were taught back in the medical school, they do not help us when we are actually dealing with a real patient who is in shock. Like, for example, if you are in a clinical situation where you are dealing with a child who is in real shock, then recalling all those tables where shock was classified into distributive, cardiogenic, hypovolemic, and then whether to know whether the preload is increased or afterload is increased, things like that, all those things are purely rubbish because at that point in time you cannot recall them. Similarly, all of these acute treatment algorithms like the EPALS and APLS algorithms, which talk about the management of shock. So they tell you like how to treat shock with fluid boluses and ionotrope supports where needed. But still, it doesn't help you in that particular situation to classify or know what has caused that shock. So in my opinion, it's all rubbish when it comes down to the actual clinical practice. Then the question is how we go about it. Like there are different methods of classifying shock or something. But over my professional career, over the last 20-25 years in my practice, I have devised my own way, which is not sense of like I haven't invented something new or discovered something new. It's basically I have gone back to the basic pathophysiology, the physiological parameters that define shock, and have tried to come up with a very simple mathematical formula which you can remember all the time. And if you just go through that, it will make your life so easy. And if you are in a situation where you are actually dealing with a kid who has got shock, so you can easily know what are the different types of shocks and where the problem lies, and you can easily then pinpoint the cause of shock, and then you can accurately manage it accordingly. So without further ado, let's dive and get started. And today this lecture is all about shock, and it's gonna be simplified ridiculously. So I hope by the end of this lecture you would know something new and that would help you in your clinical practice. So let me start with the very basic definition of shock. Now, shock is defined as a state of cellular and tissue hypoxia. Now, we know clinically when we are dealing with a patient who is in shock, so we know that basically the blood pressure is down. So we take shock synonymous with a hypotensive patient or a hypotensive kid. In most of the cases, hypotension is associated with shock, but in fact, the real definition of shock is cellular hypoxia. So the basic pathophysiology is that the cells are not getting enough oxygen, or they are not able to metabolize oxygen. Again, that's another subset of like different problems in which the tissues are getting enough oxygen, but then the cells are poisoned to the extent that they are not able to metabolize that oxygen as a fuel and do their metabolic functions. But by and large, in most of the cases, when I say most of the cases, around 95 to 98% of the cases, it's basically hypoxia in the sense that the cells are not getting enough oxygen. And why they are not getting enough oxygen? The reason is that not enough blood is flowing towards the cells, not enough blood is flowing towards the organs. Blood has got red blood cells have got hemoglobin carries oxygen. So if less blood is going towards the organ, it simply means less oxygen. So the cells have got low fuel. When they are low on fuel, they can be damaged. When they are damaged, so that is cell death, and obviously that condition culminates in a clinical situation which we call as shock. So again, as I told you, that in most of the cases, in majority of the cases, because cell hypoxia or cellular hypoxia is associated with decreased blood flow, that decreased blood flow is associated with hypotension. So in most of the cases, clinical cases, shock and hypotension are synonymous with one another. But keep it in mind that in certain cases, though they are not that common, blood flow can be normal. So in other words, blood pressure can be normal, but simply the cells are poisoned at the cellular level that they are not able to metabolize that oxygen to do their function. So that is known as cellular hypoxia, or in simple words, just like imagine it to be a form of cellular poisoning where the cells are not able to use or utilize oxygen. Anyhow, by and large, in most of the cases, it's because of inadequate blood flow. Not enough blood going or flowing towards the cells. Not enough blood going is not enough oxygen. Not enough oxygen, again, cells are deprived of oxygen. Hypoxia, shock. And because in most of the cases, the blood blood flow is reduced, that is associated with low blood pressure or hypotension. Now, you should know, if you recall your basic knowledge of physiology, that blood flow in the blood vessel and its adequacy, that you know cells need a specific amount of blood coming to that, in other words, a specific amount of oxygen all the time. That adequacy of blood flow depends on blood pressure. In other words, the body has to maintain blood pressure to maintain adequate blood flow all the time. Now, by the way, what is blood pressure? Blood pressure basically is the lateral pressure exerted by the blood on the walls of the vessels. You know, the heart is pumping all the time. Blood is being pumped. So as this blood is being pumped, it exerts some pressure on the walls of the vessels. So when it is at peak, we call it systolic. When it's at its like lowest ebb, we call it diastolic. So there is always an adequate pressure in the blood vessels because of this force of blood flowing, which we call as normal blood pressure, which actually helps in the maintenance of blood flow towards the organs. Now, moving on, I told you that back in the medical school, when we were taught physiology and we were taught the cause of shock, most of you would be familiar with this table that classifies shock into 3 or 4 types, that is hypovolemic shock, cardiogenic, obstructive, and distributive. We knew that hypovolemic shock is basically in which the blood volume is low, either because of losses of body fluids, like what happens in gastroenteritis, prolonged vomiting, prolonged diarrhea, or it can also occur because of loss of blood volume, like in trauma and blood loss. Then we knew about cardiogenic shock, in which basically the pump function is affected. So the heart is not pumping effectively because of heart failure or because of myocardial infarctions, or in cases because of certain pathologies like cardiomyopathies. In obstructive types of shock, we knew that there was some obstruction to the flow of blood from the heart, like for example in critical aortic stenosis or in coarctation of aorta, where there is an obstruction and the blood cannot adequately flow down into the blood vessels and then down into the organs. And then the distributive, in which what happens is that the body fluid is distributed in such a way that there is peripheral pooling of the blood that happens in septic shock or anaphylactic shock. And then we knew that we were taught that okay, in these cases, in one the preload is decreased, in another one it is increased, and the same goes for afterload and the contractility of the heart. Now just imagine if you are dealing with a sick child who's in shock, okay, and you are doing all your fluid boluses and anatropes. Do you have the time to recall all these types of stupid tables? Nobody can recall. I mean, even if you have got a very high IQ, still you cannot recall all that thing, okay, when the emotions and the tensions are running quite high. So I call it purely rubbish. It's of no use to me. So I put a big cross on it. Of no use, at least of no use to me. Then the question is, fine, if we cannot use this one, then how do we classify shock when we are actually dealing with it? Is there a simplified way? Is there some an easy way? Yes, there is. And I will show you how. For that, again, let's go back to the medical school. Okay, let's go back. Open up our textbook of physiology. Okay, don't open the textbooks. I will make it simplified for you, okay? Just recall that basic equation, that blood pressure is equal to cardiac output times systemic vascular resistance. Now, this is the very basic physiological equation that you need to understand, and I will explain it for you. Now, blood pressure, I told you blood pressure basically is the lateral pressure which is exerted by the flowing blood on the vessels of the wall. As it's flowing in adequate amount, it is exerting a pressure, and that is blood pressure. Now, that pressure of the blood depends on 2 factors. Number 1 is cardiac output. What is cardiac output? Cardiac output, as the name says, output from the heart. Heart is pumping, and every time it is pumping on a single beat, it pumps a certain amount of blood into the circulation. So the total amount of blood which is pumped by the heart in 1 minute, that is known as cardiac output. So very simple one, it's the amount of blood which your pump, that is the heart, is pumping in 1 minute, that is cardiac output. And then the second thing is systemic vascular resistance. Systemic vascular resistance. Systemic, obviously, all the systems. Vascular, related with blood vessel, and resistance means that there is some tension in the walls of the blood vessel. So blood vessels are pipes. But if you look at these pipes are neither fully relaxed, because they are made up of muscular, smooth muscle, okay, and in other words, you can just imagine them to be muscular pipes. But these muscular pipes are neither fully relaxed, like neither fully dilated, nor are they fully contracted. So they are in a state of partial contraction, partly contracted. And that partial contractions is what we call as a vascular resistance. It is very important, because if it simply gives way and becomes fully dilated, then it just becomes like a bucket in which like the blood is flowing and it just pools in the periphery. Then it will not be easy for the blood to come back. And it cannot be fully contracted, because if it's fully contracted, then obviously blood cannot go into the periphery. So it strikes a balance where it is in a state of partial contraction. So the body or the peripheral organs are getting enough blood, and at the same time that blood is flowing back to the heart as well. So that is systemic vascular resistance, and your blood pressure is the product of cardiac output multiplied by systemic vascular resistance. In other words, if your blood pressure is high, it means either your cardiac output is high or either the systemic vascular resistance is high. And similarly, if one of them increases, in order to maintain blood pressure, the other would go down. That's how the body would regulate. Like for example, if for some reason your cardiac output increases, like for example, you are running, you're doing some exercise, your cardiac output increases. So similarly, that has got a tendency to push the blood pressure up, and obviously it will go up to some extent. But to compensate that, the systemic vascular resistance would go down. Similar, if the cardiac output decreases, the systemic vascular resistance would go up to maintain the blood pressure. Now, at the same time, we also know that this cardiac output itself is the product of stroke volume multiplied by the heart rate. We know cardiac output is the amount of blood being pumped by the heart in 1 minute. It's 1 minute. So that in 1 minute, this is equal to stroke volume. Stroke volume is the amount of blood pumped per beat. And you multiply it by the heart rate, that would give you the total amount which is pumped in 1 minute. That would be cardiac output. So if we rewrite this equation, blood pressure is equal to, so we replace the cardiac output by its further factors, heart rate and stroke volume and the systemic vascular resistance. So the basic equation would be read as that the blood pressure is equal to the product of heart rate, stroke volume and systemic vascular resistance. Now this you should understand very well, because now you know that the blood pressure maintenance, and in other words, if the blood pressure goes down, we talk about hypotension, and if hypotension is synonymous with shock, so that would help you in understanding shock. So blood pressure maintenance is dependent on heart rate, on the stroke volume and on the systemic vascular resistance. So 3 factors. And this is what you need to consider when you are actually dealing with a child who is in shock or who has got hypotension. So how we do that? Like we need to calculate, if we have to calculate what is causing, we need to calculate the heart rate, we need to calculate the stroke volume, and we need to calculate the systemic vascular resistance. Because if if the blood pressure is down, you need to understand where the problem is. Is it there because of the problem in the heart rate is down, or because there is a problem in the stroke volume, that the stroke volume is down, or is there a problem in systemic vascular resistance, that the systemic vascular resistance is down, or is there a problem in all of them, like all of them have gone down? And that helps you in like knowing the underlying cause, because different causes would affect different factors. So you need to determine heart rate, stroke volume and systemic vascular resistance if you want to know where the underlying problem is, if you want to know what is causing the shock. This is very, very, very important. And I will tell you how do we calculate all these things. Now, heart rate, it's very simple to calculate. How do you calculate heart rate? You take the pulse. In children, very small children, you can take brachial pulse. In elder children, you can take radial pulse, or you can take pulse anywhere where you can feel for it. So that would give you the heart rate. So heart rate is simply the number of times the heart beats in a minute. You take the pulse, you have calculated the heart rate. Now, heart rate in children is age dependent. A heart rate which would give you like chills down your spine in an adult might be totally normal for a child. Like, for example, a heart rate of 160, which would be classified as tachycardia in an adult, is a normal heart rate for a newborn. A newborn adult has a heart rate of 120 to 160 beats per minute. A child around 5 years of age, 100 or 110 heart rate is normal for him. By the time they are 13, 14 years of age, then they eventually develop the adult heart rate. But usually for neonates and infants, it's very much age dependent. So you have to compare it, whether it's normal for that age group or not. So heart rate is the first thing, and you can calculate it very easily. Then the next thing is stroke volume. Stroke volume is the amount of blood pumped by the heart per beat. Now you can't open up the chest and see how much is being, or there's no like sort of a measurement beaker or something in which you can measure how much the blood is pumping per beat. So normally in advanced care, we do it with the help of echocardiography. So modern echocardiographic machines have got the M mode and the Doppler mode by which we can calculate the amount of blood pumped per beat. And that is very simple. By formula, it is the end diastolic volume minus the end systolic volume. So you know the heart is contracting, which is known as systole, and then it relaxes diastole. So when it relaxes, it gets blood. So at the end of the relaxation, it is full of blood. That is known as end diastolic volume. And when it contracts, it pumps some of its blood out into the circulation. So at the end, when it is pumped out, some of the blood is still in the heart. That is known as end systolic volume. So if you minus this end systolic volume from end diastolic volume, that is the amount of blood which has gone out from the heart in that one beat, and that would be your stroke volume. So we can easily do it with echocardiography. But again, let's say you are dealing with a child, you don't know how to use an echo machine, or simply you haven't got an echo curve, or you haven't got like a point of care ultrasound. What will you do? Okay, I will tell you proxy indicators of measuring stroke volume. Number one, you should know what is a normal stroke volume, again, which varies with age. For a child, newborn to 1 year of age, it's around 2 mils per kg body weight. So let's say a neonate who is born with a birth weight of 3 kilograms, his stroke volume would be 3 into 2, 6 mils. So his stroke volume, like in every beat, his heart is pumping 6 mils, which is a tiny amount, but obviously you can understand because it's a neonate. And let's say if he is 7-8 kg, then you can understand, let's say 8 kg infant, like 6 or 7 months old, 8 times 2 would be 16. So that his stroke volume would be 16. For those kids who are older than 1 year of age, then we have got an equation to calculate the stroke volume, and that equation is 21.88 multiplied by age raised to the power 0.32. So you probably would need a scientific calculator to do that. So for example, a child who is 3 years of age, so his stroke volume would be 21.88 multiplied by 3 raised to the power 0.32. So 3 raised to the power 0.32, I think, is equal to 1.4. And if you multiply 1.4 with 21.88, you get around 30 or 31 mils. So that 30 or 31 mils is the stroke volume for a child who's 3 years old. So this way, you can calculate the stroke volume for children who are greater than 1 year of age, and this is the normal stroke volume. I'm not talking about the disease state. This would be the normal stroke volume that you would expect for that age group. Now, how would you calculate the actual stroke volume? I told you, this is the expected stroke volume. That would give you an idea that whether your calculated stroke volume, like the actual that the child is having that disease, whether that is less than what you are expecting or more than that. I told you there are two things. Number one, echocardiography, which probably, if you're lucky and you know how to use it, that's an asset. But let's say if you're not, then the proxy indicator of knowing the stroke volume are two things. Number one is your pulse pressure. So pulse pressure is systolic minus diastolic. Systolic minus diastolic gives you a rough indication of pulse pressure. And the other thing is the volume of the pulse. So if you are able to feel the pulse, you see whether the volume is good, like if you are feeling for the pulse, your fingers are properly raised by the volume of the pulse, or you feel it's just like, it's a feeble, which we call as thready pulse. So if it is feeble, if it is like not good volume, then it simply means that the stroke volume is decreased. If it is good volume, you don't know the exact amount, but at least you know that it would be normal. Whatever you have calculated normal, it would be close to that. Why? Because it's good volume. But if it is thready, if it's feeble, then you know it is less than what you have calculated to be normal for that age group. So it's definitely less. You don't know how much less, but you know that there is a problem with stroke volume now. Then the third thing is systemic vascular resistance. Now, systemic vascular resistance, again, if you want to calculate the actual value, it's very difficult because you need to determine the right atrial pressure. So for a right atrial pressure, you need to put a catheter from the subclavian vein or from the internal jugular vein down into the right side of the heart, and that is an invasive process. So probably the cardiologist would do that, or probably that would be done in an intensive care where the intensivists are well trained in that particular procedure. So it's an invasive monitoring. Maybe in most of the EDs we don't have this facility. So how would you know about systemic vascular resistance? Again, so we use like qualitative proxy indicators. Two things: central and peripheral cap refill time. Cap refill time is a very good indicator of systemic vascular resistance. Normal cap refill time in children is less than 2 seconds. So if the cap refill time is increased, if it is more than 2 seconds, it simply means that the systemic vascular resistance is decreased. The other good indicator of systemic vascular resistance is to feel whether the peripheries are cool or not. So if the peripheries are gray or bluish and they are cold, that simply means that the systemic vascular resistance has decreased. Systemic vascular resistance has decreased. So that would lead to cool peripheries. That would lead to like peripheral mottling. Though peripheral mottling can also be caused by cold weather, or if the child has been exposed to the cold. So you have to take these things into consideration. So if there is no cold and the child is in a good environment and they've got like cool peripheries, that's another indicator that the systemic vascular resistance is down. So two things for systemic vascular resistance. Number one, cap refill time, central and peripheral. If that is prolonged, your SVR is down. The second thing, if the peripheries are cool and gray or discolored, again, it has to be systemic. It's not like one periphery is cooler than the other one. No, then it probably means a unilateral, some other problem. But if it is like systemic, like the hands and the feet, both sides are cold, mottled, and the environment is not accounting for that, then you have to think of that the systemic vascular resistance has decreased. So that way you can determine the heart rate, the stroke volume, and the systemic vascular resistance. And if they are decreased, then you know which area of this equation is being affected. And then if you know the causes that affect each of these, it's very easy to pinpoint the cause of shock. So let me discuss a few of the causes that affect each of these factors in this equation. So again, coming back, this equation is blood pressure is equal to heart rate multiplied by stroke volume multiplied by systemic vascular resistance. Now, blood pressure you can easily measure. Heart rate you can easily measure by pulse. So if the heart rate is decreased, again, if the heart rate is decreased, that would lead to a decrease in blood pressure. And again, most of the reasons that causes decrease in heart rate usually are your bradyarrhythmias. So different types of heart blocks, they can cause bradyarrhythmias. One of the other common things that can cause bradyarrhythmias or bradycardia or decrease in heart rate, leading to decreased blood pressure and sometimes even syncope, is vasovagal syncope, which is quite common in children of adolescent age group, more so common in girls as compared to the boy. So heart rate is easy to determine, and if the heart rate is down, it's either bradyarrhythmias, it's either vagal stimulation, or it might be because of some drug effect or heart blocks, so on and so forth. Now coming down to the stroke volume. Stroke volume basically, it's the amount of blood which is pumped by the heart in one beat. Now this is basically, if the stroke volume is affected, there is some problem with the pump or the factors surrounding the pump. Okay, so again, there are three things related to the heart that can affect your stroke volume. One is known as preload. The other is the contractility of the pump, that is the contractility of the heart, and the afterload. So quickly going through these three concepts. Preload is the amount of blood coming towards the heart. So remember, heart cannot pump blood if not enough blood is coming towards it. So a certain amount of blood needs to come into the heart before every beat, before it can throw that blood out. So that is preload. So if that amount is reduced, in other words, if preload is reduced, is decreased, then the stroke volume would be decreased. And some of the conditions that can decrease the preload are atrial fibrillation. Again, it's more common in adults rather than kids. Diastolic dysfunction because of cardiomyopathies, hypovolemia because of blood loss, or because of prolonged gastroenteritis or prolonged vomiting, diarrhea, or in any condition in which the fluids are lost by the body. Or it could be cardiac tamponade. The cardiac tamponade is a condition in which there is fluid in the pericardial sac, which puts pressure on the heart, and the heart cannot relax. When it cannot relax, not enough blood can come into the heart which it can flow. So all these factors, they would decrease the amount of blood coming into the heart. That means that they would decrease the preload. Number two, if there is problem or decrease in the contracting power of the heart muscle. So if there is infarction, myocardial infarction, or if there is cardiomyopathies, infiltration in the cardiac muscle, okay, though that it cannot act like a good muscle, or there is heart failure because the heart is so much dilated because of valvular problems or any other problems. So it's so much dilated, it's now a balloon, it hasn't got enough power in it to properly contract. So that would lead to problem with the contractility again. When there is contractility problem again, the heart is not able to pump a decent amount of blood into the circulation, stroke volume is down, and again stroke volume is down, blood pressure can go down. The third thing is afterload. Afterload is the amount of pressure or amount of obstruction or amount of pressure or amount of load that the heart has to face when it is pumping the blood out. When it's throwing the blood out, it does it against some resistance. So if that resistance is increased, we call it increased afterload. Like for example, the valves are not opening properly, aortic stenosis, coarctation of aorta. So what would happen? Or hypertrophic obstructive cardiomyopathy. So what would happen? The heart is trying to pump, but there is so much pressure ahead, it's not able to pump enough blood into the circulation. That would be increased afterload. And again, heart has got two chambers which pump the blood outward. One is left ventricle, one is right ventricle. So you can further dissect the afterload into afterload for left ventricle, which can occur in aortic stenosis, which can occur in systemic hypertension, which can occur in hypertrophic obstructive cardiomyopathy, or you can also divide it for the right side, right ventricle as well. Right ventricle throws blood into the pulmonary circulation. So if there is pulmonary hypertension, obviously there will be less stroke volume going into the lungs. Or pulmonary embolism, which is though rare in children, but like for those who are dealing with adults, pulmonary embolism another cause, okay, where the stroke volume from the right side of the heart would be reduced. That means increased afterload. So if there is reduced preload, reduced contractility, or increased afterload, all these factors would decrease the stroke volume from the heart. And reduced stroke volume means reduced stroke cardiac output, which means reduced blood pressure, which means shock. Why? Because less blood flow, hypotension, less blood going, less oxygen, cells don't get oxygen, they die, shock. Then the third thing is systemic vascular resistance. Now, systemic vascular resistance, I told you this is basically tension in the blood vessels of the peripheral tissues or peripheral parts of the body, so that an adequate circulation is maintained. So if there is a vasodilatory state, like if these vessels, they give way, the tension goes away, so what would happen? They would just dilate. So what would happen? Blood would simply pool. So blood is coming, but it's not going back. So it's pooling in the peripheral tissues. We call it, in other words, if you go through the through the previous tables like this, and then it's basically a distributive type of shock because the fluids are being distributed. So all those vasodilatory states which can occur in sepsis, it can happen in anaphylactic shock, it can happen in adrenal crisis, it can happen in neurogenic shock. So all these types of neurogenic, anaphylaxis, sepsis, what would they do? They would decrease the systemic vascular resistance because of peripheral vasodilatation, and blood would pool into the periphery. So when blood would pool into the periphery, it would not go back, and again heart is not getting enough blood back into the circulation, it's not pumping enough, and then what would happen? Blood pressure would reduce. Now because there's not enough blood in the blood vessels, rather it is pooling in the periphery, and that is reduced systemic vascular resistance, and that means blood pressure is down. Blood pressure down means hypotension. Hypotension means shock. I told you they are synonymous with shock, except those causes in which the blood flow is adequate but the cells are not able to metabolize, but that's like are very rare. So for practical reasons, most of the time in shock you would be dealing with hypotension, and you must know what is causing a decrease in blood pressure, whether it's the stroke volume, whether it's the heart rate, or whether that's the systemic vascular resistance. So when you are dealing with a patient who is in shock, you need to determine whether there is some problem with the heart rate. Now in most of the cases, practical cases, when you are heart rate is usually increased. So if heart rate is increased, normally this blood pressure should go up. So blood pressure is down. So what does that mean? If heart rate is going up, there's definitely a problem either with stroke volume or with systemic vascular resistance, or a combination of both. So we need to see where the problem lies, because if you know where the problem lies, then it's easy to manage the underlying cause. Because obviously symptomatically you can treat shock with the, let's say, fluid boluses and with inotropes, but you need to address the underlying conditions, because if you don't need the underlying condition, then what would happen? You would get a few minutes with the patient, but again they would deteriorate. So it's very important to determine the underlying, and that you can only do if you focus on this equation. So remember, you're dealing with shock, your heart rate is equal to, your blood pressure is equal to heart rate multiplied by stroke volume multiplied by systemic vascular resistance, and quickly go through that. Oh, heart rate is up, okay, so there is problem with stroke volume or with systemic vascular resistance. Okay, let me quickly go through. I don't have the echo. Okay, let me take the pulse pressure. Okay, let me check the volume of the pulses. Okay, if the volume is good, pulse pressure is fine. Oh, I don't think there is any problem with the stroke volume. Then definitely what is left? Systemic vascular resistance. So you focus on that. How would you know about systemic vascular resistance? Look at the cap refill time. Look at the peripheries. If they are cool, so your cap refill time is increased, the problem is with systemic vascular resistance, and then also know the causes. So it's either sepsis, it's either anaphylaxis, it's either adrenal crisis, or it's like some form of neurogenic shock. It's easy. With other parameters and your clinical examination and maybe a little bit of investigation, you would be able to pinpoint whether that is sepsis, whether that is anaphylaxis. Like in anaphylaxis, you might have a rash, the child might be having a stridor or wheeze, and then you can give intramuscular adrenaline to address that. Otherwise, if you give them fluids and other thing, that would not address the underlying cause. So they would still be in danger. You need to address the underlying cause, and that you can only do if you focus on this equation. If the pulse pressure is down, if the pulses are of low volume, feeble, thready, the stroke volume is down. So it's either decreased preload, it's either problem with the contractility, or it's problem with the afterload. So again, with the history and with the clinical examination, you can focus on that and you can address those issues. So again, what I am focusing here is that you just need to know this equation, that blood pressure is equal to heart rate multiplied by stroke volume multiplied by systemic vascular resistance. And you should know if blood pressure is down, either there's problem in heart rate, either there's problem with stroke volume, either there is problem with systemic vascular resistance. If there's problem with stroke volume, either there is reduced preload, either there is problem with the pump, or either there is increased afterload. And I've told you the causes. If you just focus on these causes, remember them, you can pinpoint your underlying cause. So I hope this is now clear to you. Let me quickly go through an example, and that would further clarify it. So let's say there is a 3-year-old child who's got a history of fever, and he's been vomiting for the last 5 days, and he's brought to emergency department because he's suddenly deteriorated and he becomes very floppy, he's unresponsive, and on presentation he is pale. He's got a temperature of 38 degrees Celsius, he is tachypneic at 60 breaths per minute, his heart rate is up at 180 beats per minute, his cap refill time is 4 seconds, which blood pressure is down at 60 by 30. So let's say this, obviously you know this child is in shock. So what parameter is affected causing shock? Now this child, let's say you have pressed your emergency buzzers and you're trying to let's say find out and trying to put an IV line in, and at the same time you are thinking what has caused this shock. So just quickly go through the equation. And what is the equation? Equation is blood pressure is heart rate times stroke volume times systemic vascular resistance. Okay, now in this case the blood pressure is 60 by 30, which is down. You are dealing with shock. Okay, fine. Issue number one, is it problem with the heart rate? Heart rate is not down, in fact it is increased 180, which is increased normal than for what is normal for this age. So you have only problem with stroke volume, or you have got problem with systemic vascular resistance. Now next thing, you look at the pulse pressure. Pulse pressure in this case 60 minus 30 is equal to 30, and let's say you check for the pulses. The pulses are of good volume. His heart rate is 180, but the pulse is of good volume, so there is nothing wrong with the stroke volume. Obviously if you've got bedside echo, well, that would be excellent if you can do it, but if not, well, fine, leave it. Now the problem is in the systemic vascular resistance. Why? Because that child has got cold peripheries and he's got a cap refill time of 4 seconds. So the problem is with decreased systemic vascular resistance. Okay, why? Because he's mortal, he's got cold peripheries, and his cap refill time is increased. So what could be the reason? Now with this, systemic vascular resistance is most commonly reduced in what? In sepsis, in anaphylactic shock, in adrenal crisis, or in neurogenic shock, because he's got temperature, he's been having a history of vomiting. So most probably you are dealing with sepsis in this particular case, or there could be another possibility of adrenal crisis as well. Okay, so what you do, okay, you start with your fluid boluses, and at the same time you do a cap gas, and if the cap gas is showing increase in lactic acid, then obviously you are thinking of sepsis. But let's say if it is showing reduced sodium, reduced glucose, and increased potassium, then you're probably dealing with adrenal crisis. So it's easy if you just focus on this equation. Remember, you are dealing with a shocked child. You just need to remember on this, focus on this equation, that is the blood pressure is equal to heart rate times stroke volume times systemic vascular resistance. I have told you the causes of decrease in heart rate, decrease in stroke volume, and decrease in systemic vascular resistance. If you focus on that, and if you can determine the stroke volume and systemic vascular resistance by the proxy clinical methods that I told you, like, you can just pinpoint the diagnosis and you can manage it effectively. So my friends, I hope you have understood what I was trying to explain. I hope you have learned some new methods of dealing with a shocked child, whether you are dealing in a hospital, whether dealing in a clinic, or dealing with such a child in emergency departments. So if you have learned something new and you enjoyed this lecture, then give me a thumbs up, and please share this lecture with your friends. And so far, if you haven't subscribed to my channel, please do subscribe, because it helps in maintaining this channel. And most importantly, if you still haven't understood anything, or if you have got any questions, the best thing would be you can put your questions down in the comment section below, and I will try my level best to answer them as soon as possible. So wishing you a very happy day. Take care. Have a good time. Bye-bye.